Last week, we introduced you to the world of pharmacy benefit managers. Though many assume these negotiators are the cost of high, often unaffordable drug prices, our experts explained how they're a small part of a much larger issue. However, that doesn't make them completely free from criticism. Matthew Fielder argues that the rates insurers pay PBMs to negotiate is often much higher than necessary and can cut into the savings that are passed on to us, the consumers.
We're in a situation where about 80% of the market is controlled by the three big PBMs. And that gives those PBMs quite a lot of leverage when they're negotiating with their clients to say, you need someone to administer your drug benefit. You need someone to negotiate with manufacturers. You need someone to negotiate with pharmacies. I'm, one of three people who can provide those services. So pay up. And so I think it is the case that PBMs are extracting more compensation from their clients than they should be able to extract. That's probably not a huge amount of money relative to overall drug spending. I think it's probably on the order of several percentage points of our overall drug bill. But that's, our overall drug bill is a lot of money. And so, even if you could squeeze those profits a little bit, that's potentially billions of dollars in savings a year. So I think my overarching view here is no, PBMs are not the reason we spend a lot on prescription drugs, but is there room to sort of squeeze PBMs' profit margins and deliver some savings to payers and consumers? Probably yes.
Fielder is a senior fellow in economic studies and in the Center on Health Policy at the Brookings Institution. But while pharmacy benefit managers are paid a lot on one end, Eric Levine, a principal at Avalier Health, says that their participation in other areas may even out the scales. He recently published a white paper on PBMs which shows that they can make a big impact through the clinical programs they operate, like automatic refill programs.
A barrier to taking your drugs is not having the drug. So sometimes they'll offer 30-day automatic refill programs, 90-day automatic refill programs. So members have a constant supply of their maintenance medications. So there was one study that showed positive outcomes in there's a measure called the medication possession ratio. So it's kind of like has to do with, does the member have the drug? And so the PBM found in this study, participants who were in 30 or 90-day programs had better possession ratios than participants who were not in that program.
Levine's paper estimates that PBMs can save their clients billions of dollars. The hope is that these savings get passed down to the consumers, but it's unclear how much this goal becomes a reality. One survey shows that 75% of employers who contract directly with PBMs find them to be at least moderately transparent about the savings.
And so that means that when they're doing these contract negotiations, they're having those honest conversations with the PBM of saying, how much money are you saving me? How much am I seeing of that? Is that trickling down? What does that make my final premium? The premium being what the employer is paying to the PBM. And then the employer decides how much am I charging my employee versus how much am I paying.
Levine and his colleagues found that up to 95% of rebates can get passed on from the PBM to their client. Rebates are the discounts negotiated with drug manufacturers. However, just because they can be passed down doesn't mean they always are. Furthermore, the clients, which are often employers and insurance companies, are able to decide if they want to pass on those savings to us, the consumers, or use the money somewhere else.
That's out of the PBM's control because they're just in the contract with the client who's saying, maybe the contract's like the PBM will pass through 95% of the rebates with the client, and that's agreed upon. If the client doesn't pass all that rebate on to the consumer, that's not on the PBM to do because the contract is really just with the client, not with the end consumer.
So in an ideal world, the savings would trickle down to make life a little easier for everyone. But that's not always what we see happen. And though it's not always the fault of PBMs, they become a main focus for legislators. Earlier this year, the Federal Trade Commission released a second interim staff report on its ongoing investigation into pharmacy benefit managers. It concludes that the big three PBMs, CVS, Express Scripts, and Optum Rx, have hiked costs for various life-saving drugs. They've been able to increase revenue while the rest of the industry and consumers have seen a steady increase in drug costs. In the wake of this report, Levine cautions that it's important to have both sides of the argument to truly understand what the analysis is showing.
I think it's important to scrutinize and say, was the data analysis done correctly? Is it saying the right things and finding the right things? So I feel like the FTC investigation is an important topic to be doing, and certain in the sense of like understanding how the health system works. Is it being done correctly? I don't know if I have the authority to say yes or no on that. I just think that it's important that we take an objective look, make sure that the full picture is being taken a look at.
Still, legislators have been looking to pass laws centered around increasing transparency and PBM reform as a whole. But as some people wonder if we should get rid of this middleman altogether, Levine says that wouldn't be a magic fix to America's healthcare issues.
Well, what does a world without PBMs look like? An employer is going to have to go to Pfizer, go to Eli, go to every drug company and negotiate that contract with them. They're going to have to process the claim, whether it's the health plan who does it, or maybe the health plan won't do it. And they'll be like, well, now I need to find a claims processor. And now I need to find someone to help my members stay on drugs. And so like by taking this one action based on the premise of like PBMs are evil, get rid of them, you've now created such disruption in the system. Maybe you've just added more cost because now an employer is managing all these different vendors, all these different functions. So it's very nuanced, and you just want to make sure you're not creating a game of whack-a-mole in any of the actions taken.
In general, Levine and Fielder agree there needs to be more education around pharmacy benefit managers so that we can make specific and impactful changes to the system.
So I don't think the PBMs are saints by any stretch of the imagination. They wield a lot of market power, and they're using that to extract more profits than they probably should be able to earn if this market was working better. At the same time, I think they're actually not responsible for most of the things that people don't like about their prescription drug coverage. And so I think we sort of need to hold two ideas in our head at the same time. The PBM market isn't working as well as we'd like it to, and PBMs are no angels, but there are also a lot of other problems in how our health insurance system deals with prescription drugs, and that are probably actually like bigger contributors to the things that patients really don't like about how their drug coverage works.
And in a world where the title middleman has become somewhat of a negative label, Levine challenges the public to reframe their perspective.
Calling them the middleman, well, yeah, they are the middleman, but is that a bad thing? Maybe, maybe not. Would you consider like Amazon the middleman? I mean, yes, Amazon is the middleman of your purchasing, right? Like I'm buying a phone charger from them, I'm buying a piece of furniture, but like, do I want to be going to each individual store and doing that? Maybe not. Like I like having a marketplace.
You can find more information about Matthew Fielder, Eric Levine, and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.